Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. About 1 in 5 people who are diagnosed with colorectal cancer today are under the age of 55, and colon cancer is now the leading cause of cancer-related deaths in men and women under age 50. For help understanding what's important to know about colon cancer, I'm talking with colorectal surgeon Dr. Joseph Valentino, director of the Colorectal Cancer Program at Upstate. Welcome back to The Informed Patient, Dr. Valentino.
Thank you. Appreciate you having me.
If I understand correctly, the rate of people being diagnosed with colon or rectal cancer has dropped since the mid-1980s, but that's mostly in older adults, and the incidence in people under age 50 has actually been increasing. Do we know why?
That is correct, first of all, that we have seen the numbers decrease in those for whom we're performing surveillance. So it does seem that surveillance is effective and has been helping to prevent cancers. Unfortunately, we are seeing a rise in people under screening age, and that's particularly problematic because these are patients in whom we're not already performing surveillance and trying to look for cancers. And so maybe that we're relying on symptoms and other things, which can often be later on. To answer your question directly, that is still to some degree up in the air. And there are a number of things that are being looked at as far as what might be causing this rise in the young population. And that can be a really hard thing to sort out. One of the problems is that this often involves decades of exposure, and trying to pinpoint a specific item that may be causing this finding can be very challenging. One of the more common reasons is having a genetic predisposition to developing colorectal cancer at a young age. There are diagnoses like Lynch syndrome or FAP where people can get cancer at a younger age because they were just genetically predisposed, but it is not very likely that our genetics have changed significantly in these last few decades. So that means that something is happening environmentally that is driving these kinds of problems. Some people have noticed links between certain diagnoses or conditions, obesity, and maybe higher rates of metabolic syndrome. Those things that may be happening at a younger age may be partially driving some of these findings. But I'll say that in practice, it's not uncommon that the people that we encounter who have these sorts of issues are young, healthy people. And so I do think there's probably something else that's a significant contributing factor. People have looked at items like the microbiomes, the way that either antibiotics or how we eat or what our lifestyles are like. Are they changing the kind of bugs that normally grow in our gut? And some of those are healthy and help out. Other ones may cause inflammatory changes. And could those be a contributing factor? I've even seen things where people talk about changes in how we use aspirin and other medications that may have been more common in childhood back in the day that we don't do as much now, and whether that could have an impact or reduce cancer risk. And it's something that our young patients are not exposed to in the same way in their younger years. And that's not advocating for an increased use, the reasons that those have changed, but just kind of highlighting that there are a lot of things that can cause problems, cause changes, and it can be difficult to sort out. Other big ones are items that'll show up in the news, things like ultra-processed foods. And I think that was a popular item here not all that long ago where the WHO put the processed meats on as a class 1 carcinogen, that there is a link between those. Increased red meat intake may be driving some of those changes or problems, or at least may have a link to it. Then there are a number of other items like microplastics, the forever chemicals, pesticides, things that we're putting on our foods. Could these things all be contributing factors? And I think any of these could end up being linked. Whether there's a single item that is causing this change, I think that still has to be determined. And there's a lot of effort being put in to try to figure out, why is this happening? What is causing this to our patients? But I think some answers are still in process.
The American Cancer Society recommends colon cancer screening starting at age 45, I think it is. How often are you seeing patients that young? And if in general the rates are increasing in young people, is there any talk of lowering the screening age lower than 45?
Right now, the change to 45 was even a relatively recent development. We were seeing increased rates, and as we looked at the benefit in the people over 50 versus those in that 45 to 50 range, it looked like we might have a shot at saving equivalent number of life by doing screening at a younger age. Even though we are seeing a rise in young patients with colon and rectal cancer, they still represent the minority of the total patients who do develop colon and rectal cancer. You are still more likely to develop it past screening age than you are underneath. And for a test to be effective, there generally have to be enough people who have it in a given group for it to be helpful. Otherwise, you have to test a tremendous number of people in order for that to have value. I do think that there will likely be some further changes that will be happening at some point, but it's going to take time and studies, I think, to figure out who and how and when we can most effectively do that. To answer your question, do I see this? Absolutely. I recall first noticing this in my practice and talking to my partners almost a decade ago when I was still relatively early on in practice, where we just kind of anecdotally noted that there seemed to be more young people. At the time, I thought maybe it was just people concentrating into an academic practice. And then over time, it became more and more clear that we're seeing younger and younger people who have cancer. It is not uncommon at all that I see people in their 40s, even younger than 45. I've certainly taken care of patients in their 20s and 30s. I've even taken care of a few teenagers who had colon and rectal cancer, and those we weren't able to find a genetic reason in those specific cases. And it is really heart-wrenching to see that happen. Part of that too is because the whole reason we do screening is we don't want to wait for symptoms. We don't want people to finally show up because they were bleeding or they were having bad changes in their bowel habits or anything else, because often it's pretty far along by the time those sorts of symptoms start to develop. And so in the younger patient population, we don't go looking until those symptoms arise. And that same problem can happen then by the time those symptoms show up. Unfortunately, it can be farther down the path. And so I do think some changes will likely need to happen. I think in the meantime, being aware that this can occur, and it's not to say that you need to be scared about this and worry about every time there's a hemorrhoid or other things. There are other diagnoses that can sometimes cause these changes. So being aware that these symptoms can indicate a problem, that it may be that someone needs to go get checked out. At a minimum, talk to their primary care physician. And then I think also amongst primary care physicians, making sure that they are aware of the increased incidence that we are seeing more young patients, and that we don't want to just write these off as a benign problem, as something that we don't need to worry about, especially if they persist or they don't respond to treatment or they seem like they're more than usual, they're more than is typical. Then it may be worth talking to a GI provider or a colon and rectal surgeon or whomever to see if we need to do some additional testing and sort out a plan, or at least rule out a bigger problem.
How does colon cancer differ in a young person compared with someone who's older, or does it differ?
I think that one of the biggest things I would say about that is how it can impact a person in their younger age versus when they are older. Whether the genetics of it, the microbiomes, all those other things that I was talking about, I think that there will be ongoing research in that area. But I will absolutely say that if you're a young patient, this isn't on your radar anywhere. You're thinking about your job, your career, often your family, some of these people with very young families. And to suddenly get hit with a diagnosis like this, to suddenly have to face your mortality at an age that is far younger than you ever thought you were going to need to, that is a very challenging thing. And it's hard at any age, but especially for somebody who's young and should have so much of their life ahead of them, it's a really tough problem to face. And I think that's one of those big differences and big things that we need to keep in mind as we're figuring out how to approach this problem.
How do you go about diagnosing colon cancer?
So ideally, if you're in a screening population, that we do a screening test. So in those patients who are 45 years or older, it may start younger depending on your family history too. And that's something else to keep in mind. If you had a first degree relative who was diagnosed with a cancer or an advanced polyp at a younger age, then often we'll start screening at 10 years younger than the age of diagnosis. So if you have been diagnosed with colon or rectal cancer, it's worth making sure your family knows so that they can go get screened, so that any siblings, children, that they can get the appropriate testing done at the appropriate time. We also will sometimes start that earlier, so potentially screen somebody at age 40, as opposed to doing the longer intervals where we may go up to 10 years. We may do it every 5. The intervals, the timing, when and how we go about screening does change depending upon some of these factors. As far as the test is concerned, one of our old tried and true methods, and what I still consider the gold standard, is doing a colonoscopy. That does involve getting cleaned out, which is not anybody's favorite thing to go through. There are a variety of preps that are available now, including split dose preps, where as opposed to doing it all in one setting, you may do part the night before, the rest the morning of. And some people may be able to tolerate or clean out a little better with that. The colonoscopy does require coming in, having an anesthetic, but it's not uncommon that rather than the conscious sedation of old, that many of the times we'll do what's called monitored anesthesia care. They'll be given a medication to make sure that they're asleep. And so it can often make it more comfortable as you're going through the procedure. And so that may be another thing that's a little bit easier than it might have been in the past. The advantage of a colonoscopy is it lets us look directly. We can potentially intervene on polyps while we're there. So if we find things that look like they're going to turn into a cancer, which is what a polyp would be, at least an adenomatous polyp, then we can remove those. If we find something more advanced, then we may biopsy or talk about other procedures, but it has both that diagnostic and therapeutic ability. There are other tests out there, including FIT testing or FIT DNA. So one of the most common ones that you hear for that is basically stool testing. Cologuard is the one that most people see on commercials. It does still have a pretty high rate of detecting cancers. They usually talk about a 92% detection rate, which is what they advertise in all their commercials. That does mean that we are missing some of the cancers. The same is true even with the colonoscopy, though. It isn't a perfect test. But if it helps get more people screened, then I think that's great. On board with whatever helps us at least take a look and try to find those people who might have a bigger issue. If it's positive, you will still need a colonoscopy. There can be some false positives, which means that it shows up as positive, but nothing is there. But either way, we would follow that up with an endoscopic exam to try to find that. It can detect some polyps. So that is one of the differences you see between that kind of testing and a colonoscopy, is that the precancerous things it may not detect as well, especially if it's not particularly large or advanced yet. But similar to what I talked about for that above 50 versus 45 to 50 age range, where it looks like we may be able to save an equivalent amount of life, that seems to be what Cologuard might offer as well. And that's why it was approved. So I'd say those are probably the two workhorses right now. There are some other options that may be available under different circumstances, like, CT colonographies and then other modalities that we may apply a little bit more selectively.
Well, let me ask you, if you do find something, if you remove a polyp or some tissue that doesn't look right and you send it to the lab, what information do you get from that? Are you going to be able to tell the patient yes or no, they have colon cancer? And can you tell them how extensive it is just based on that one sample?
So if we find something more advanced, we will take biopsies, and it may show us a cancer. One of the most common types in the colon or rectum is something called an adenocarcinoma. And if we find that, so find invasive disease, then that means that we think a cancer is present. There is something called sampling error. That means that sometimes we may see something that looks pretty concerning, and we take biopsies, we take pieces of it, but it's not the same as taking the whole thing out, and it is possible we miss. And a comparison I sometimes use is if you have a big bowl of M&Ms, and green ones are the good ones, the red ones are the bad ones. The red ones would be the cancer. You can randomly pull a handful out and get only green, but it doesn't mean that the red wasn't there. So there are times where we need to do confirmatory testing or repeat exams, or we may say, I know what the pathology showed, but I'm highly concerned that there's something there that we need to do something about. And there are even advanced polyps, and there may be other ways short of surgery or other interventions that we can pursue if we do find that. But I would say that's our starting point, is trying to prove what we're dealing with and then figuring out whether we need to do any additional testing or if we feel like we have a diagnosis in hand. As far as how far along it is, once we figure out what we're dealing with, if we see that it does look like a cancer, at that point, we want to stage it. We want to figure out how far along it is. And most people are familiar with staging, and broadly, there's usually 4 stages, and the lower numbers are earlier, the higher numbers are more advanced. We often will do a CT of the chest, abdomen, and pelvis, because the most common places for a colon or rectal cancer to go would be to lymph nodes, to the liver, to the lungs, and then sometimes it can spread inside the belly, what's called carcinomatosis. And so those are some of the things we're looking for. And in colon cancer, often we're just trying to figure out if there's stage 4 disease or not. Is there metastatic disease or not? And surgery, if we don't see that, may be the next step. There are some nuances to that as well, but I think broadly speaking, that's often how we would look at that. For rectal cancer, it gets a little bit more complicated because we may add in other treatments before we get to surgery, things like chemotherapy and radiation. So we'll do a pelvic MRI for rectal cancers to try to give us an idea of the local stage. And what that means is just how far along this is in the pelvis. And that will help tell us whether we need to do treatments up front, whether we need to go straight to surgery, or what kind of surgical techniques may be on the table. So it can vary some depending on location and what we find in those images as far as what happens next.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Joseph Valentino, director of Upstate's Colorectal Cancer Program. Now, the Upstate Cancer Center's Colorectal Cancer Program includes surgeons, yourself, medical oncologists, and radiation oncologists. Can you explain how the program works for someone who has a new diagnosis?
Colon and rectal cancer has certainly become multidisciplinary, more and more so over time. It does involve surgical care. It involves medical oncology. Those are the chemotherapy docs, radiation oncology, so the ones who provide radiation. There are also other support staff and physicians who can potentially be involved. That it can include the radiologists who can help with interpretation and various other people who participate in the care. So if you are referred over, and it may depend on how far along your disease is as far as where it's referred to, but let's say a referral sent to our office, then we'll look over that information. We'll figure out what imaging or testing may still need to be done. We'll obtain some of those outside records and pathology reports so we know what we're dealing with. And then depending on the anticipated level of complexity or possibly following a visit based on what we find with that imaging, we do have a multidisciplinary conference. So we'll actually meet in a room to discuss pretty much routinely all of our rectal cancers as well as some of our more complex colon cases. And that's where all those physicians that I just mentioned can be together, talk over the cases, make sure that we're in agreement with the findings and that we know what our next steps and our plans are going to be. And that can help expedite care. It can help make sure that we're all on the same page as far as what treatment needs to happen. And then you'd come in for a visit. We'd go over that information. We'd talk about what that next step may be. If we need to get you in with other providers, then we may place a referral to the medical oncologist or radiation oncologist. It's also not uncommon that we'll work with physicians or providers that may be closer to home because we do certainly see patients from across the region and we do want it to be convenient for them. We want to make sure that they're able to get the care that they need. Not everything can be done locally, but we try to do our best to accommodate when we can.
The phone number for people who want to call on their own is 1-315-464-1800 or 315-464-HOPE, HOPE, which is 4673. But do you prefer that a person have their primary care provider make the introduction?
Often you will be referred by whomever was working you up. If you have a cancer diagnosis, someone has already been working with you in order to establish that diagnosis. And they can absolutely send a referral over to the cancer center or make a call to those numbers, or we have relationships with a number of providers in the area or the region who can reach out when we need to get somebody in to be taken care of. So that's the most common way that that will happen. Those numbers that you mentioned, if you're looking to try to get screening. So let's say that you don't know that you have a cancer diagnosis. It's just time for you to get screened, or maybe you have some symptoms that you're worried about. Then those are numbers that you can call to see if it's a situation where we may be able to establish care or have a visit with a nurse practitioner. I would say there it is probably still most common that you've been interacting with your primary care physician or your GI provider, and they can send a referral up. That is a very common pathway. If you express concerns about some of these diagnoses, they can certainly send a referral over as well. So I would say there are a number of ways that you can go about that, but it is pretty common that that ends up being a starting point as far as initiating workup. Hopefully you're established with somebody too. I mean, even in these younger years, having a primary care provider, somebody who can help make sure that you have all the testing done that you need, that can start surveillance at the right times. I do think that's a valuable thing as well. That's another one that I think sometimes, in our younger years, it just may not be as high on the list of priorities, but it is still a good idea to make sure that you have somebody both to try to prevent things from happening. And if something comes up, then you have a way to act not just on colon rectal cancer, but on whatever healthcare need arises.
Let me ask you about follow-up care for someone who is successfully treated for colon cancer. What is life like for them after that? Do they still have colonoscopies?
Surveillance is a key part after you're done with care. Stage 1 cancers can potentially be cured with surgery alone. And those stage 1s, we often don't do as intensive or surveillance afterwards. Even those who do go through surgery, we still need to do endoscopic surveillance. We want to try to make sure that they don't develop additional cancers or have additional lesions that we'd want to take care of in the future. Everybody else, though, because of that risk of it coming back, that's where we do more intense surveillance. So CT scans, physical exams, labs, and endoscopic examination. And what I mean by surveillance is that when we see you in clinic, we have a pretty good idea of what's going on. It's honestly pretty incredible that we can see inside the human body with something like a CT scan or an MRI, but it's not perfect. It cannot see down to the level of a cell. And so there can be things that are there that even when we're going to do surgery with curative intent, we think that we're getting out everything at least that we know about. We know that sometimes things can pop back up later on. So we do want to watch closely, and that is really, it's with the hope that nothing shows up. But if it does, that maybe we can catch it at a time where we can still do something to try to treat it. And so that involves physical exams. So coming in for a visit, doing a history and physical, it involves labs, it involves imaging. And yes, most definitely you will have colonoscopies moving forward. And anybody who has had a history of cancer, they're always deemed to be a higher risk for future cancer. And so they also fall into that category similar to what I was talking about with the family history, where we watch people more closely. We do it more often than we would the average person, the average individual out in the population.
How often does colon cancer recur?
That depends on the stage, on how far along it is to begin with. And so that already is a discussion based on what your pathology ends up looking like or imaging findings, sometimes how procedures or surgeries went or other treatments went. With stage 1, we can get cure rates over 90%, even 95%, that with surgery alone. If it's farther along, those numbers do start to drop. If you have metastatic disease, sometimes trying to do surgical intervention is not always on the table. It depends on the circumstances. But obviously, if it's already spread elsewhere, we're behind the 8 ball a little bit more under those circumstances. And the likelihood of recurrence does go up, even if we're able to do something aggressive. Sometimes we do even shift more into just trying to prolong life through things like systemic chemotherapy. We're just trying to slow it down the best we can, even if we can't get rid of it. So rather than a precise number, I would say that we may have treatments on the table. It does depend on when we catch it and as to what we're able to do about it. I would also say that this is one of the reasons that doing screening, that trying to detect this early before it's symptomatic, before it has had a chance to grow or spread, is so important, because if we find something early, it is likely that we can do more about it.
So let me make sure I understand, though. If someone has a history of, say, prostate cancer or breast cancer or lung cancer, does that put them at an increased risk? Do they need more vigilance in their colon cancer screening?
For colon cancer, I would base it more on genetics and family history, and it happens commonly enough that that's why screening is as effective as it is for this particular diagnosis. That's why we're able to do it for colon and rectal, really, regardless of those other ones. Having a family history of that in a first-degree relative definitely does increase. Having a personal history of cancer, there are certain genetic diagnoses that can show up with other types of cancers. If we start to see some sort of a link, or if we find something as we're testing for colon or rectal cancer diagnosis, or we notice something in what it looks like as we evaluate the specimen, or we see a bunch of polyps in your colon or anything along those lines that start to tick up that risk, we may even have you do genetic counseling. So basically talk to somebody who can figure out if doing a test to see if there's a genetic predisposition for cancer is worthwhile. So the way I would put that is we may factor those things in, but it kind of depends. And certainly if people have multiple cancers, there may be something going on, either a genetic issue or maybe there was an exposure that is driving these kinds of findings or problems. But I'd say it kind of depends on what we find. I would take that on a case-by-case basis as far as what tumor types we're seeing and what your history looks like, what your family history looks like, and those other findings that I mentioned as far as where we put your level of risk. The ones you did mention do often have other screening modalities as well. And I'll tie that back into working with your primary care physician. Make sure you are getting tested for those too.
Before we wrap up, can you tell us about some advances in colon cancer treatment that we might be able to look forward to in the coming years?
There are always changes happening in really medical care in general, certainly in cancer care. One of the fields that I've seen the most movement, even since I've been in practice, which has been a little over a decade now, is in rectal cancer. How we went about approaching it with what we called neoadjuvant therapy, where we gave chemoradiation up front, and then people would pretty routinely go to surgery afterwards. Then we started looking at total neoadjuvant therapy, where we started moving the systemic chemotherapy, so the treatment up front, to make that treatment before you went to an operating room even longer. Things like watchful waiting or organ preservation have come into common practice now. And that's where, under select circumstances, rather than having to go do an operation, we may be able to see if you completely respond with those interventions alone, and whether we're able to just keep an eye on things, do that surveillance I was talking about, rather than going to an operating room. To clarify, that does not happen even in the majority of patients, and that is by no means a guarantee, but these are things that have already changed just even in the time that I've been in practice. Techniques are constantly evolving. So as we get to minimally invasive techniques, laparoscopy, robotics, some of the endoscopic approaches that we've been able to take, so things that people can do with the cameras now, I think are constantly evolving. Detection is another one where people are constantly trying to make efforts to see if we can better detect cancer or recurrent cancers. Things like circulating tumor DNA, what role that is going to play long term and how much benefit it has is a little bit up in the air at the moment. But I think that will continue to be a part of research and trying to figure out better ways to find this, better ways to treat people, and hopefully achieve better outcomes. And I guess actually tying into that too, even other chemotherapy options, things like immunotherapy have become available for certain types of tumors or certain patients. So people are constantly working on this. We are trying to advance care, and it becomes a continuum. And a lot of it comes down to trying to figure out, when do we have enough data to support a new technique, a new approach, a new treatment, while also not waiting so long that we're missing opportunities to treat people with some of these. Some things pan out, others don't. But I'm sure the future will hold something incredibly exciting and interesting, and just have to see what it brings.
Well, Dr. Valentino, I appreciate you making time for this interview. Thank you.
Absolutely. Thanks for having me.
My guest has been Dr. Joseph Valentino, an assistant professor of surgery at Upstate and director of the Colorectal Cancer Program at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.